is the Associate Residency Director at Cooper University Hospital.
Hello.
And he has graciously volunteered to be a guinea pig for the placement of an ultrasound guided IV. I've never done this before, so this should be very exciting and
Aren't
interesting.
you an ultrasound fellow?
Shh, don't tell my fellowship director. Right. That's, so the places
Don't take
you can
forever
look,
with this thing, okay? Just
I'll
do the thing.
drag it out.
Yeah.
So there's a few places you can look for an ultrasound guided IV. One of my favorites is I'll have the patient rotate the thumb up and look in what's called the intern vein or the cephalic vein. So you just gently place this down and look and scan along, and you can see sort of that decent sized vein right there, about a half a centimeter below the screen. You can see that it's nice and collapsible when you put pressure on it, and then as you track, it sort of goes straight up and down. And as you can see, based on how little pressure I'm putting, that the tiniest amount of pressure will completely collapse it, so you have to be careful. Obviously, this is currently untourniqueted. So this is one of the first places that I will look, because the forearm will preserve your higher vasculature for later access. The second place you can look is up in the axillary. You can look up in his bicep area, and if you look through here, you'll see right there. You see the nice pulsating brachial artery. Next to it, you see the superficial and the deep brachial veins. Those are okay to use. You see the brachial nerve right there, so it's typically not the best idea to go after that one. I would rather suggest you go after the basilic, which will run a little bit more medial and superficial, and sometimes when you have a little bit of musculature, it's a little bit deeper as well.
A little bit.
Little bit. So right there. So it's about a centimeter deep currently, and then you can see how it comes together and it joins up with the superficial brachial, and then it'll eventually all dump into the axillary vein. So what we can do, Dr. Byrne, do you have a preference for site?
You can go for the
Okay.
basilic, that's fine.
All right.
Basilic's usually a really good target, usually big.
Yeah.
That's the idea.
And let us know how the experience is from the patient perspective as well, because
Yeah,
we've
no
all
problem.
put these in 100 times, but I don't know if, I think the last time I had an intern put one in on me, I ended up with black and blue marks too.
Yeah.
Lift up your arm for me, sir.
Well, that's why I'm having you do it, sir.
God you're
Unfortunately, I've only done one today. All right, so tourniquets are always helpful, and as you can see, we'll look back at the vessel, and the vessel usually gets significantly bigger. So right there, you can see that the basilic and the superficial brachial get nice and large right there.
Great looking
Alright.
vein.
So the other thing to remember is before you start, you always make sure left is left and right is right on the screen. So we'll do that here. And left is left, right is right. All right, so we are now essentially set up. We'll prep the site. We'll get this cleaned up.
You okay, Bernsey?
I'm good, yeah. Sir, do you think it's a good idea to have the machine on the other side of the patient?
100%. Having direct line of sight to what you're doing and to what the machine is showing you is essential, especially when you're first starting out doing this procedure. And I mean, I'll tell you, right? So you've all put this in hallways. You've all put this in as there's people pulling by you, and that makes it significantly harder. But to truly do this well, you need to have the ultrasound machine in line of sight. You need to be able to look from here and say, I can look and see what I'm doing and move at the same time. So we'll look again. Right about there, nice big target. You'll prep the site. Dr. Byrne, you'll feel a sting very shortly. I'm going to give it a few seconds for that to finish drying. So then we also use these long angiocats. They're about 5 centimeters long, actually 4.9 to be precise. Now, the thing about site selection is you want to make sure that you choose the largest target that you can find. Right here, Dr. Byrne?
Yeah.
And you want to choose a target that's between 0.3 and 1.6 centimeters deep, because that gives you the highest likelihood of success. All right, so you're going to feel a big poke. 1, 2, 3. So there's needle in the skin. So now what you do is once you're just somewhat in the skin, you move the needle a little bit. You see it right there? Right there in the subcutaneous tissue. We're now advancing.
Try bouncing it and see what that looks like.
There you go.
So if you're not sure where the needle is, try bouncing it, and then you get an idea of where the needle tip is just based on the tissue deflection, even if you can't see the needle tip.
Which way should you bounce?
Vertically. Is that particularly painful? You're doing okay?
It's okay.
All right, so now you see right there, you see where it's bouncing right over the vessel, its vessel wall itself. So now as we advance, we will enter the vessel right there. Pops into the vessel. Now you'll start shallowing out your angle. So then the best way to do this when you first start out is just to walk it in the entire way. So that means I'm scanning forward with my left hand, losing sight of the ultrasound, losing sight of the needle tip, and then I'm advancing my needle tip again, scanning forward, and continuing until we are essentially hugged. The other thing you can do when you get a little bit more advanced is you can look in long axis, especially if the location is getting a little bit hard for you to flatten anymore, which we're currently reaching that spot. So we'll look in long axis, make sure we're in a good place, which we are, and as you can see right there, that's where the needle is. And then I advance while watching to make sure that it stays exactly where it should be.
Wow.
And then you hit the button to retract your needle, and there's blood.
Beginner's blood.
Yes.
So much blood.
So much blood. Always remember to draw back on your catheter once you're done,
Don't give me an air embolism, dude.
which is why you draw back once you're done, to make sure that you get the air out of the line. So you can open that. So draw back, see a good amount of blood, and then you can inject. And now Dr. Byrne can get a bag of fluids to ensure that he can finish the session.
Nice job, Sarab.
Thank you, sir. How did that go for you?
It's fine.
Was it more painful than a regular IV, you think?
I haven't had a regular IV. I think it's about the same.
What about securing? Do you have any tips for that?
Oh, that's a good point. Thank you for asking, Dr. Walinchus. So typically I will try to make sure we put the tegaderm right over, secure it with sort of the entire assembly covered up, right? So we clean that entire area before we start it, secure it down this way, and then once you take this off, I'm a little aggressive with tape, so I will put at least 3 to 4 strips across, most importantly right there. Now remember, you can look with ultrasound and see that there is at least 3, maybe 4 centimeters of catheter in there. So it's unlikely that this is going to go anywhere because there's just so much catheter available. But that being said, you still want to make sure it's secured well, especially if you're using this for administration of something like a peripheral pressor. So I'll tape it down once there, I'll tape it down once over the actual needle assembly, over what, catheter assembly, and then I'll pull this over and tape this down a third time there as well. And that's it. And now Dr. Byrne can even move his arm.